you so much for that warm welcome and also for the organizers for inviting me to talk today about a very fun topic, which is how we can partner clinical microbiology with our antimicrobial stewardship. And just a few disclosures real quick. Most of them are from research funding because I do have an infectious disease research laboratory. Okay, so first of all, I'm going to talk about what is diagnostic stewardship, which is something we use a lot more in the clinical microbiology world, and then also what is antimicrobial stewardship, and they have overlapping missions and how they can work together. And then I have a list of stewardship collaborations I'm going to go through, and these are just examples of all the different points in contact between antimicrobial stewardship and the clinical microbiology lab, where we can consider interventions that really might lead to good patient outcomes. And the idea is not to be comprehensive, but just kind of give ideas so that we can, when you're thinking of interventions that you might want to implement at your site, kind of give you thoughts and ideas for creativity in where you might want to place those efforts. And then at the end, I'll talk a little bit about designing and assessing stewardship interventions and how to evaluate if they are effective. So first of all, I'm going to talk just briefly, like, what is antimicrobial stewardship? Obviously, we've been talking about it all day, but really it's the idea is to educate and support healthcare professionals outside of pharmacy, outside of infectious disease, to follow evidence-based guidelines for prescribing and administering antimicrobials. And I like the 4Ds because we have something similar. I'll show you in the next slide. Really, the idea is right drug, right dosage, right delivery, right duration. And that fits in line with all the things that we have seen at this conference and especially previous talk. But the idea overall is through the 4Ds, through the education and support, is to curtail the emergence of resistant organisms, which everyone knows is a huge problem within our hospitals and also, from our talk earlier today, within our with our veterinary practices and environmental and the environment as well. So what is diagnostic stewardship and how is it different from antimicrobial stewardship? And like I said, this is really what the lab or clinical microbiologists are more used to thinking about, but it's modifying the ordering, performing, or reporting of a diagnostic test to improve the diagnosis of and treatment of infections and other conditions. And so instead of the 3Ds, we have the 3Rs: right test, right patient, right time. And this allows us to kind of really optimize and improve patient care by diagnosing our patients with infections or, ruling out infections if that may be the case, while by the testing that's being done. And downstream effects are, promoting appropriate antimicrobial usage in the same goal in reducing antimicrobial resistance. So just kind of two overlapping circles. And how do they overlap? I'm sure you can guess because you work with these topics every day, but really inappropriate testing is a huge problem because it drives a lot of inappropriate antimicrobial resistance. So you can see here in this screenshot, which was in the Society for Healthcare Epidemiology Diagnostic Stewardship Task Force manuscript. It has a list of inappropriate test use and then potential consequences. A lot of them are overdiagnosis, sometimes a misdiagnosis, sometimes a patient comfort issue, but really too much testing or testing in the wrong patients drives antimicrobial use when none is warranted. Also, it drives excess cost because of the antimicrobial use, the increased patient length of stay in the hospital, and then again, it drives antimicrobial resistance. So you can see how stewardship, antimicrobial stewardship, and diagnostic stewardship are slightly different, but share a lot of the common goals. And so really it's natural that they partner up in a hospital situation, such like as Endeavor Health, where I work, because really antimicrobial stewardship focuses on the antimicrobial use. Diagnostic testing is the number one driver of antimicrobial prescribing. And so if you can prevent test misuse and test overuse, you are going to automatically influence antibiotic prescribing. So, like I said, the goal of this talk, I'm going to now go into a bunch of different scenarios, but the goal is really to spark creative thinking when exploring antimicrobial stewardship interventions and to think about what you might want to implement in your hospital. A lot of the examples I'm going to be using, I pulled from the literature, and it's not a promotion or this is what I want to do at my hospital or this is what we do. It was just to give a broad experience of options that you might consider. Some maybe you're already doing in your own hospitals or you've heard of being done at places. Others might be a little too aggressive for how you feel like your physician partners and hospital culture would respond negatively. I think that some of them really push the boundaries of that. But I think thinking broadly only promotes creative thinking and kind of gets you out of that box of what is possible. Okay. So I'm going to start with laboratory testing, which is more on the diagnostic stewardship side, but I'm going to really highlight um, antimicrobial stewardship outcomes as well. And the first one, many of you may be familiar with. So this is rapid diagnostic testing for blood culture. And there are many forms that this comes in: multiplex PCR assays, blood culture panels, hybridization assays. Some people do rapid MALDI-TOF mass spectrometry on like young growth of bacteria growing in culture. We have some direct from whole blood, which our fungal speaker talked about earlier today. And then we have some rapid ID and susceptibilities testing, which is kind of the new wave of, I would say, the newer players in this space of rapid diagnostic testing. And so for a long time, these have been evaluated within the microbiology laboratory, and it's easy for us to pull data from there because we are totally in control of the data we're generating. We implement an assay and we will look at things like, did it give us the correct ID? What was the turnaround time to results? And those are very easy data for us to pull. But really, once we show that in the laboratory, we have a good result, it really only matters if we export that beyond and look at outcomes beyond the laboratory and what happens to the patients. Are they having are our pharmacists able to escalate or de-escalate antimicrobials faster? Are we having better outcomes for our patient, better 30-day mortality outcomes, less readmission, less death, less morbidity, things like that? And that data is much, much, much harder to gather. So that's why there are less of those studies, but I have a few I want to highlight. And the first one I included because it is my favorite, even though it's from 2015. And this is using the BioFire BCID assay. And the reason I love this manuscript is really it was the first time that I had seen, we've had these assays for a while, but it's the first time I saw a randomized control trial where patients within the same hospital got different, I would say, different rapid diagnostic testing access. And it was just so well done. It's a favorite. I got to include it. So this was done at Mayo. There were 617 patients with a positive blood culture, and they randomized into 3 different arms. So as soon as the blood culture went positive, they got assigned either standard process, which was culture, or group number 2, maybe you got the rapid diagnostic test and you got a templated comment. That means like it was reported with a comment or whatnot, maybe giving you some kind of guidance on antimicrobial use. And then group number 3, which was very ahead of its time back then, was you got your rapid diagnostic test, you're going to get your templated comments, and then you're going to get real-time antimicrobial stewardship feedback. So this is really measuring the effect of the rapid diagnostic test and the effect of stewardship, which hadn't been done before at this time. And so the primary outcome they're looking for is duration of antimicrobial therapy. Secondary outcome, they wanted to look at escalation, de-escalation, and then the general patient outcomes, hospital length of stay, mortality, cost, all those patient outcomes, but also things to make our administrators happy, which is cost. And what they found here, I'm going to orient you. You can see along the x-axis is time. So at the top, you can see hours listed, 0, 12, 24, etc. And then you can see the three groups. The control is their standard of care. Rapid multiplex PCR, remember, had templated comments, but you would just get that passively reported into Epic. And then the PCR, rapid multiplex PCR plus stewardship is the bottom. And what you can see is that red is the organism identification and the triangle with the E is escalation. So we'll start there. And you can see that actually escalation for the control group was happening before the identification was back. So that shows that patients were not, or providers were not using the ID to make that escalation decision. They're probably factoring on things like how the patient's condition was doing, if they were concerned, maybe after talking it over with the team about antimicrobial resistance or things like that. And when you had the multiplex PCR in both with or without stewardship, you can see that ID came much faster and escalation happened right after that. So I think that's perfect. That shows that the rapid diagnostic test definitely was able to drive escalation of antimicrobials when needed. Now, the thing that I thought was very interesting and kind of unknown at the time is the upside down triangle with the D is de-escalation. And you can see that in your control group, the de-escalation happened just after 36 hours, so maybe 40 hours. And with the rapid multiplex assay and commons, it happened slightly sooner, but really not statistically so, about the same time. So providers were willing to escalate based on that ID, but they weren't willing to de-escalate. And that's probably because they didn't have all the antimicrobial susceptibility information they needed. But again, that's in green. You can see they got their AST at the same time. So they still didn't have it. Maybe they were like not quite comfortable de-escalating antimicrobials at that point. But if you added in stewardship, you had significantly sooner de-escalation of antimicrobials, and that was not due to the assay. It's the same patient population, same providers, it's randomized. So really that is all the effect of antimicrobial stewardship. So I guess I always divide stewardship into active and passive. So active is like reaching out, whatever method that you have at your institution, handshake, stewardship, stopping by, putting a note in the chart, anything to say that de-escalate is kind of like a sign off, that de-escalation, like we see this, we think it's appropriate, kind of giving permission if there's a little bit of unsureness. And so here you can see that active antimicrobial stewardship was the single most important factor in the de-escalation portion. So, and that's not the only manuscript that shows this. This is a cost-effective modeling where they looked at a bunch of different types of rapid blood culture identification assays. And it's a little bit older, so some of them aren't used as much anymore, like PNA fish, but they looked with and without stewardship. And just to orient you, the y-axis is the average cost of a strategy. So you can see that here, that's cheap, at the top, expensive. And along the x-axis is quality effectiveness of a strategy. So quality is quality years of life. And they kind of set their axis at D, which is conventional culture without stewardship. So that's kind of like where we're starting. And they have a bunch of different, it's a meta-analysis of different studies that were available. Not all of them are great, and they really lacked data for the most part. But what you can see is rapid diagnostics with stewardship, which all start with A. They kind of were all over, but most of them were more cost effective and added more quality years of life than other strategies. So I think that that's an overall great picture to have and really show that stewardship is very important. Okay, I'm going to show you one more blood study before we go on. This one's a brand new one. And it's a direct from blood bacterial testing and the effect on antimicrobial de-escalation. So this is actually the assay, if you're in here for fungal, they talked about a direct from blood yeast assay. This is the bacterial counterpart. It detects those 5 organisms there, mainly escape pathogens, and a direct from blood, no incubation. So you don't have to put in a blood culture bottle. You just draw it and test. And yes, this company has been liquidated, and no, you can't just use other reagents or whatnot. Like as soon as you run out of your reagents, you are done. You can't change a tube with so much as a tube without being out of FDA compliance. So this is not one that's currently available, but I thought it was a good study because how well it was done. It's a randomized clinical trial of 500 adult patients from the ED, either suspected of having a bloodstream infection or receiving empiric vancomycin. Their patient groups were blood cultures plus this direct from blood bacterial testing, or just blood cultures alone, kind of routine. And primary outcome, they were looking for time, they're looking at de-escalation, so time from randomization to last dose of intravenous vancomycin. And secondary, they were going to look at anti-pseudomonal de-escalation. And for this one, the lab fulfilled, I would say, what our goal was. We resulted our reports on average 5.2 days faster, and that's because a lot of these blood cultures are negative. So at 5 days, they're going to, they're going to result as negative. But unfortunately, outside the lab, on the clinical side, you can see there's no difference in randomization from last dose of IV vancomycin or anti-pseudomonal beta-lactams. You can see that they have the treatment arm that's in red, they have the usual care, standard of care in green, and they completely overlap. So both arms did have active antimicrobial stewardship. So why did I include this? The reason is most of the studies I'm going to include here had a positive effect on patient care. They were wins for antimicrobial stewardship. And this one, if you look at the test, you're like, yeah, I can see how that would be a win, and it's going to give us a faster result, and clearly it's going to be better for our patients. The reason I included it is because until you do the study, you do not know if it's actually going to have an effect outside the lab. And maybe the problem, I think there are a lot of the issues are just that the targets, it was 5 targets, they're not broad enough to really allow providers to feel comfortable de-escalating antimicrobial therapy. Maybe their antimicrobial stewardship was too robust and they weren't able to de-escalate further. But yeah, I'm including it just to show that it was a very well done study, and until you do the study, you don't know the answer. So you got to try, you got to do the study. It's not a foregone conclusion. Okay, I'm going to move over to asymptomatic bacteria. And I know we had a whole session on this today, but this is bacteria in the urine in the absence of signs and symptoms of infection. It's very common, 5 to 15% in healthy individuals, much higher in elderly, and about 100% in those with chronic urinary catheters. And so treatment for these they're not infectious. Treatment for bacteria cultured from this environment is very common. So a lot of times we do urine cultures because they're easy to do and you don't really know what's going on with your patient. You don't want to miss anything. So you might take urine cultures for altered mental status or leukocytosis or just abnormal UA and a whole host just because you're not sure if you should or you don't want to miss it. And this study cited here showed that about 75% of ED patients received antimicrobials for asymptomatic bacteria despite no documented signs or symptoms of UTI. And then once started, antimicrobials often were just continued for the duration of hospitalization. And they said a lot of that had to do with just the culture of the organization, at which the study was done, and what people did during fellowship, kind of they take with them throughout their career. So they'll just keep it on because they're not really sure if they need it or not, and it's already started, so why not? Okay, so we want to discourage this, right? These are patients who are not going to benefit from antimicrobials, and this is a diagnostic and antimicrobial stewardship problem. It's more urine cultures, mean more growth of bacteria, which means more antibiotics. So looking at this over time, a lot of different strategies have been used. There's educational nudges, so information present either at the time of ordering or at the time of resulting the urine culture, requiring providers to select what symptoms the patient might have, computer decision support, something in Epic to either pop up or have a list saying like these are appropriate reasons and these are inappropriate reasons for urine cultures, and then urine analysis with reflex to urine culture. And this is when you do a UA, and then depending on what parameters you set, you reflex to a urine culture only if if it meets certain criteria. Those criteria are a little bit nebulous at this point. They're very different for different institutions, and you can make the UA with reflex to culture optional. You order the UA separately, the culture separately, or you can do UA with reflex to culture, or you can make it mandatory, which means that there are only very specific exceptions without which patient or providers have to use the UA to urine culture reflex pathway. Okay, so this is a study this year out of the VA. There were actually 3 VA hospitals, and they used different strategies to try to combat try to affect diagnostic stewardship and antimicrobial prescribing for patients with asymptomatic bacteria. And so this is an elderly population. There's going to be a lot of these asymptomatic bacteria cases. Hospital 1, they used a nudge comment. Hospital 2, they used clinical decision support. And Hospital 3, conditional urine reflex culturing. And I'll go into those in just a second. But important to know, like, these were not 3 hospitals just out of nowhere. They already had some pre-existing diagnostic stewardship interventions. You can see for Hospital 1 didn't really have a lot except for restricted reporting of some antimicrobials. Hospital 2 had some computer decision support and a laboratory conditional reflex urine culture set at 5 white blood cells per high power field, some cascade reporting. And Hospital 3 already has some computer decision support and some restricted antimicrobial. So they had a little bit there, but they're going to implement some new strategies. So what were the strategies? Hospital 1, the nudge, they just added a urine culture report comment advising clinicians not to treat asymptomatic patients. So when you get your report back, it says E. coli greater than 100,000 CFUs per mil. If your patient doesn't have symptoms, don't treat them. Hospital 2 is a little bit more nuanced. They had the nudge already that Hospital 1 implemented. They require documentation when ordering of at least 1 UTI symptom based on the results from step 2. Either it would, like, depending on what symptom they chose, if they chose foul smelling urine or something like that, that's not really a criteria for UTI. They would either tell them if it's appropriate, it would proceed to culture. If not, they would say kind of your decision, whatever you checked was inappropriate and you don't need a urine culture, and wouldn't let them, a soft stop, wouldn't let them really go through with that selection if it was inappropriate. And then, like I said, they had a pre-existing urine reflex culture policy with the 5 white blood cells per high-powered field. And then Hospital 3 had the most stringent policy. Urine cultures were only performed when the UA had greater than 10 high-powered fields or cells per high-powered field. So more restrictive UA, and that's all that they were doing. So what did the outcomes look like? They looked at the primary outcome was mean urinary tract infection antibiotic days on therapy, and the blue line separates the before and after the intervention. So you can see that actually at Hospital 1 and Hospital 2, the solid black line is what you're going to be looking at for mean antibiotic days of therapy. And you can see it's actually higher afterwards than it was before. So really, I would say the intervention wasn't great, didn't really work. And if you look at Hospital 3, They are the only ones that had a statistically significant drop in the ordering there, in the, sorry, days of therapy there. And it was mirrored by a decrease of about the same amount, so about 40% of urine cultures, whereas there was no change in urine cultures at hospital 1 and 2. So really, if you were able to drop urine cultures, what would happen? You would drop antimicrobials that were being used on those patients for inappropriate urinary tract infections. So yeah, I thought that was a really nice comparison, especially when we're thinking about when we're thinking about asymptomatic bacteria. And here's a more aggressive approach I found I just wanted to touch upon, but this is a study where they looked at non-catheterized inpatients, and if you had a positive urine culture from a non-catheterized patient, it got the following comment. The majority of positive urine cultures from inpatients without indwelling urinary catheter represent asymptomatic bacteria. And if you strongly suggest your patient has a UTI, call the microbiology lab. Now, I would never let this fly at our hospital because I don't want to call all those people. We actually have a reverse comment that we use at our hospital. It's somewhat similar. Except for we use it on Foley catheters and they call infection control. So it works out great for everyone. But what did they find here? They actually found that it's a very small study, very small number of patients because they were hands-on with every patient, and obviously this couldn't really be scaled in its current form or current workflow. But they found of the 37 positive urine cultures that got the comment. Most of them did, only four of them met the CDC criteria for UTI, and it only generated, of those 37 positive urines, only generated 5 calls to the lab. 4 of them were for cases where they had deemed via chart review that they were ABS. And half of the ABS cases were treated before the study in their baseline group. So it really did cut down the number of patients treated from 48% to 12%, but super small group. And I don't think in our large healthcare system like the one I work at, we would be able to pull something like that off with our current staffing and the culture. But I like the idea of kind of like putting something out there that maybe requires further action to get a urine culture released, but in very specific situations. Okay. I'm going to move on to laboratory reporting decisions. And these are things outside of testing that maybe we can work with our stewardship groups on just to change the way we're reporting things to have better stewardship outcomes. So the first one I want to talk about is not new, but it's cascade reporting. And the idea here is that only frontline only like the narrow first-line recommended antimicrobials are reported in the susceptibility report. And then if you find resistance, it kind of spits out the next like lowest broad spectrum antimicrobial and then the next one after that. So in this case here, you can see ceftriaxone would report on everyone. On the, I guess on your left-hand side is all the drugs if you were reporting without a cascade. On the right-hand side is ceftriaxone. Most people would only see that. But if it was resistant, then you get cefepime. And if that was resistant, you get meropenem. So kind of channeling providers to make the choice that you want them to make for antibiotic selection. And so the pro here, like I said, directs those providers to pick the drug you want them to pick, the lowest spectrum possible, the most narrow spectrum possible for that condition. The con is that sometimes there are situations where because of drug allergy or other situations, you may need another drug, and so you have to call the lab. So it can be work on those providers. But it's not like rocket science that this would have an effect on antimicrobial prescribing, but I always like to see a study that points out what we think is going to happen. And in this case, you can see that there's an effect. The center instituted cascade reporting. At baseline. All antimicrobials were reported, and cascade reporting was in fact in the post-CR patients and they evaluated antimicrobial use. This is only for ceftriaxone susceptible E. coli and Klebsiella isolate. So the data that I'm going to highlight is only for those patients that could stay on that lowest spectrum of antimicrobial, not for ones that would have been resistant and needed a cefepime or a meropenem. But what you can see right now, hopefully the boxes will guide you, is the cefepime, because it wasn't reported in any of these patients, because remember, they're all ceftriaxone susceptible E. coli and Klebsiella, went down significantly, although not to zero, went down, I believe from 1.2 to 0.8. I believe these are days of therapy that they were looking at. And our narrow spectrum antimicrobials went up. So ceftriaxone, which would have been reported, went from 1.4 to 1.6, and cefazolin went from 0.6 to 0.7. So that makes sense. We're decreasing broad spectrum antimicrobial use and increasing narrow spectrum use. And when they looked at their patient outcomes, because we always want to make sure our interventions do not harm patients while we're doing our best to reduce those broad spectrum antimicrobials, they showed no differences in C. diff and mortality, and they actually saw a reduced 30-day readmission, although that was not significant, but the shorter length of stay was significant. So a win-win, I would say, for everyone there. And this is something that CLSI, our Clinical Laboratory Standards Institute, makes it very easy to help with. This is one of the charts that they have in their M100 document. And you can see that it lists all antimicrobials by tier. And for that reason, it makes it easy to kind of figure out what would be a good cascade reporting or selective reporting. Selective reporting is kind of where you test a frontline group. And then if that is resistant or meets certain criteria, you're going to test like another panel. It kind of helps you define what would be good candidates in both the preliminary reporting and the reflex, depending on your patient population. Okay, moving on to everyone's favorite, which is antimicrobial resistance reporting. Just real quick, we're going to talk about AMP-C and AMP-C beta-lactamase resistance mechanism. So these are beta-lactamases they can be both on the chromosome or they can be plasmid mediated and transferred from bacteria to bacteria. And they exist in three kind of different expression groups that we think about. One is uninduced, and that is this, I don't know if I have my point here, but uninduced is going to be this low level here. You can see resistance to penicillins and variable resistance to first generation cephalosporins, but otherwise pretty susceptible. Induced is the high level AMP-C. That's where you get resistance to first, second, third generation cephalosporins or cephamycins. And then constitutively expressed. And most of the constitutively expression is on plasmid. So it's going to be transmitted to organisms, and you'll only know it's there if it's highly expressed. Just to set the baseline there, the chromosomally encoded AMP-C organisms are listed here. So a lot of our Enterobacteriaceae have AMP-C on the chromosome. And unfortunately, there's no CLSI approved or commercial testing for induced AMP-C. So you don't really know how many, if you have a bacteria, if you're going to have that induced AMP-C, or if it's just going to stay in the low expression, the derepressed state on the chromosome. So the questions that we think a lot about in the clinical micro lab and we talk about with our stewardship group are kind of what are we going to do with these chromosomally encoded AMP-C? So should we test as reported? So that means if I test cefepime on a Morganella and it's susceptible, do we just put that out there? Or are we going to automatically flip all cephalosporins for not all, first, second, third generation cephalosporins and penicillins? Are we going to flip those to resistance to prevent possible induction of the AMP-C if it is low expressed. So clinicians don't need to know this information and worry about it. Does it depend on the organism shown here? Does it depend on the source? And I would say that yes, all these things do matter a lot. And also there's no there's not a ton of standardization, especially within just a quick survey of our Chicagoland hospitals. All the hospitals are doing something different for AMP-C and then also other beta-lactam resistance mechanisms, your ESBLs, your carbapenems. So yeah, it does matter. So I guess one of the things I wanted to look at is the upregulation. Like, how often do we get that induced state where it's on, where we know AMP-C is on the chromosome, but it's going to escalate and become resistant to third generation cephalosporins? And it turns out there are no great studies. I just want to start there, but this is the best one I found. And definitely it's estimated that some organisms have a higher reversion rate than others. So you can see along the bottom is different organisms, and along the y-axis is the mutation rate. That's upregulation of the AMP-C to a higher resistance level. And you can see that there are 4 organisms here at the bottom that kind of have bars at the higher reversion rate. And those are Enterobacter cloacae complex, Enterobacter aerogenes, now Klebsiella aerogenes, of course, and Citrobacter fundii complex, and then Hafnia alvei. And we don't need to talk about that anymore because we see that so infrequently in the lab, it kind of gets forgotten, but it is also a high reverter right there. Other AMP-C containing organisms, the induction rate's quite low, generally less than 5%. So we really do focus on this group right here. And recently, I would say there was a lot more variation in what labs did. Recently in 2024, IDSA put out some treatment guidance. They say there's a moderate risk for clinically significant inducible AMP-C production in the organisms that we just showed in the paper had the higher mutation rate, and that they wouldn't recommend ceftriaxone and piptazo for the treatment of these organisms, except in uncomplicated cystitis. So that goes to show both like the specific AMP-C containing organisms we kind of treat a little bit differently than the entire list, and that it definitely depends on the source as well, where we would restrict use really of the third generation cephalosporins. And I think this is a good example of antimicrobial stewardship balance and collaboration with the clinical lab, because it really is a balance. If we report all the third generation cephalosporins of all of these Enterobacteriaceae with AMP-C on the chromosome as resistant, regardless of how they test, that's really going to drive up a lot of broad spectrum, like 4th generation higher, use for these very common bacteria that we see every day, but also like what are the outcomes and how are we going to make sure that patients at risk for upregulation or inducible AMP-Cs are not put on third generation cephalosporins when we know they may generate resistance over time. So it really is a balance in knowing your patient population, your providers, how much antimicrobial stewardship efforts that you have to kind of work with the clinicians, to kind of to figure out where you fall on this. And then, of course, this is one mechanism. I'm not going to talk about all of them, as is not my favorite thing. But we also have ESBLs, we have carbapenemases, and we have a lot of situations like that where you have to decide how you're going to report different antimicrobials, and it's going to affect your use of broad spectrum antimicrobials. So it's just really a balance and communication between lab and stewardship. Okay. So next, I'm going to talk about reporting in the lab, as far as there's a strong association between laboratory reporting and prescribing of antimicrobials. So if you have a positive culture, and generally many times that is enough for physicians to treat it. If we always say, if we name it, they will treat it. I think that's pretty much true. If I tell providers you have like this wound culture, superficial with 2+ coag negative staph, they might be like, okay, that's just cutaneous flora. If I tell them it's Staph urolithicus or whatnot, this is a staph species I had not heard of prior, but it's just a basic coag negative staph. They're going to be like, oh, that doesn't sound good. We must do some treatment. And so how can we design laboratory reporting to prevent treatment of commensals and normal microbiota that may be contaminating our specimens? So this was a nice study out of New Zealand. They looked at wound and a super large number of wounds, skin swabs, and sputa. And I just want to point out exactly, this will come up again, the two categories that they this was a retrospective review, and they looked at two different categories. On the top here, you can see test and treat, and that is where the sample is collected. They immediately started antimicrobials. When the culture was reported, they either continued with those antimicrobials or adjusted them as needed. But what I'm going to talk about more is tested weight, this bottom portion right here. That's when they collected the sample, they didn't start antibiotics, the culture was reported, and then at that point, either the patient remained off treatment or PRAI stands for post-report antibiotic initiation. So basically, they got the culture, they either stayed off antibiotics or they got prescribed antibiotics. And so what they looked at here is in the test and weight category, they had about 35% of the wounds and over 50% of the sputa. And when they looked at the culture report being released, they found that 30% of the wounds and skin swabs had antibiotics prescribed, and about 23% of the sputa. But how did it break down based on reporting categories? You can see here in the red, their options were no significant growth, no significant growth, mixed growth, or name the organism. And if you name the organism, you can see that 43% of the wound and skin swabs and about 47% of the sputa were treated. If you said mixed growth or insignificant growth, about 10 to 12% were treated with antibiotics. So really it does show that if you name it, people are more likely to treat it because they think it's an indication from the lab that this is a serious infection when that may not be the case. And so just working with stewardship around how we're reporting things to make sure the message is clear about different organisms. And a cool study in the same group a few years later is they did an exception reporting approach for wound swab cultures. So what happened is they would look at the superficial wound swabs, and if the pathogens present were susceptible to empiric therapy, which would be in their case cephalexin, they said they did not report them. And then they just had a culture comment that went out, no significant resistant organisms detected. And if culture fell outside this procedure or this flow chart on the left up here, then they would do their standard reporting, which would be ID and susceptibility. And so really you can see that at the top, the workflow was they received the specimen, they cultured it. If an eligible organism was isolated, that's MSSA. MSSL was methicillin susceptible Staphylococcus. Hadn't heard that abbreviation before. Or beta hemolytic strep. If those were isolated, they would then they would go into this yes category, and they had a few exclusions there, but not a ton. And then if you didn't have an exclusion, then you would get your exception reporting. You get your no significant resistant organisms isolated there. So what did it tell us here? So they did a large number of samples, and we're looking specifically at the test and weight approach. So pre-change, they had about 1,800 cultures, and post-change, when they implemented exclusion-based reporting, they had about 700 and some. And really, out of the 700 cultures, about 53% met that criteria for exception-based reporting. And what they found is using the same test and weight, looking back on patients who were not prescribed empiric antimicrobial treatment, when the culture report was released before the change, about 50% of the wound swabs patients with these wound swabs received antibiotics, and post-change, it was about a quarter. So they really did cut down on the amount of antibiotics prescribed, whether you would feel comfortable with, with that exclusion-based reporting. It was a new one for me, but like an interesting concept, I would say. And they did look at morbidity, mortality of the exception-based reporting group to make sure nothing poor was happening to their patients. And they found that there were no obvious changes to that. They didn't go into it a ton in the paper. So just something to keep in mind. Okay. And then similarly, I have a paper on respiratory culture nudges. And this is a study with 210 patients. And they took respiratory cultures and they would add a comment about respiratory cultures. Well, here, pre-intervention, they just said commensal respiratory flora. Post-intervention, they would say commensal flora only, no Staph aureus, MRSA, or Pseudomonas aeruginosa. Just to kind of give the providers a little bit more about what is in that commensal flora. And they specifically pull out organisms that often change antimicrobial prescribing and may be a cause for de-escalation if they are not present. So what did they find? They found that pre-intervention, you can see that they were looking at antibiotic de-escalation or discontinuation. They were able to do that in about 40% of their total patients, broken down by anti-MRSA and anti-Pseudomonal therapy. Post-intervention, about 75 or just under 75% of their total patients were able to be de-escalated. They also were able to reduce acute kidney injury in the intervention phase, and they had no difference in all-cause mortality. So again, you're reducing your antimicrobial usage, you're reducing acute, like adverse patient outcomes due to antibiotics, and you're not affecting the mortality. So something like this can be really useful for that de-escalation when coupled with active antimicrobial stewardship. And the great thing about this is it was a respiratory culture nudge. I think it happened in 2016. And a lot of our interventions, it's like once you're done and you evaluated it, hopefully you can talk about it, publish it, and then you move on to the next one. Well, you got to keep looking at them because sometimes providers fall off of maybe what they did when there was intense education and intense like focus on this one project. So they actually look back 3 years later, 3 years, after the initial intervention, and the nudge was still in the respiratory culture report. Initially, they did in-person training and they had educational handouts for the ICU prescribers and inpatient pharmacists. 3 years later, they didn't do any additional education, just continued with the nudge. And they found that they were able to maintain and even increase in some situations the antibiotic de-escalation or discontinuation. When the initial intervention was 2016, and then the follow-up period was 3 years later. So you can see it had a lasting effect, and I think that's really important to point out as far as these stewardship interventions, because obviously we don't want them to work just during the 6-month study period. Okay, I'm going to talk real quick just about antibiograms, which I'm sure you guys are very familiar with, but this is an example of our traditional antimicrobial antibiogram. And the benefits are that it's really like a snapshot of antimicrobial use in the last year, but it doesn't have a lot of nuanced information and maybe what are some things we could do with our antibiograms to influence antibiotic prescribing. And some things that others have tried are having syndromic antibiograms. So right now, traditionally, they're all comers, everything from blood to superficial wound swabs, kind of all put together, which doesn't really reflect what's going on in the hospital. And definitely patient conditions aren't reflected either. So like I said, you could do syndromic, also weighted incidence systemic antibiogram. So basically that just means like I'm pulling ICU patients over 65 with these certain conditions. Really, I would say that the WISCA would require an intense IT presence to be able to pull that data and really pull it up in a moment's notice. But I think the syndromic antibiograms do have some use. And so we've tried a few of these where I work from time to time. So you can see we did cephalexin testing You can see for urines only and non-urine, and the idea here was so that our IC providers would see how susceptible cephalexin was for E. coli when they were looking at urine prescribing for urine cultures in the ED. And then more recently, we've broken down our E. coli and Klebsiella by inpatient urine, outpatient urine, and other, which would be bloodstreams and every wounds and all kinds of things like that. And it's just to give providers an idea of when it might be appropriate to use and when not. I would say some of the downsides here is like you need 30 isolates. So to really have statistical significance. And so if you break your categories down too far, you really don't have the significance that you need to make decisions. But I think in some large categories, it can be really useful. Another thing that we do sometimes is we combine years if we don't have enough enough data to actually have 30 isolates tested. I would say the pros are, we can actually get some data on these infrequent organisms that are isolated but are still very important. The con is, like, of course, as you stretch over time, it may not represent your current state of those antimicrobials. So just something to keep in mind. And then I just really want to touch real quick on these interventions. So what can you do if you want to do a stewardship implementation? I would say definitely in the planning phase, you want to narrowly define the goal of the intervention. And I say narrow, 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 because like once you start looking at one thing, you want to look at more and more and more, and it bloats, and then you never get this off the ground. So make them small. Definitely, you want to involve key stakeholders, lab, pharmacy, ID, any groups that are going to be impacted, and identify your support, both physical, so labor, equipment, and emotional / at the hospital, who's going to help promote this and kind of push it forward and develop strategies for end user adaption and acceptance. Like, who's going to be your cheerleader for the projects? And once you have identified and implemented an intervention, you need to track the effects. And again, don't assume it's going to be one way or the other. You have to just take it as it comes and adapt and look at antibiotic use, patient outcomes, cost savings, anything that can help promote what's going on here. Maybe give you a clue if it's not working, what you could change to get it to work. Solicit feedback and modify as needed. And then I would say definitely publicize the wins. This is within your hospital to build support for future antimicrobial interventions externally through posters, presentations, and publications. And that's because in doing this talk, I found so much interesting data that I could see how other people did studies, what they tried. Maybe I don't want to do the same thing, but I want to do something similar. You need to get that data out there so other people can see what you've tried, so they can maybe think they might want to do something similar. So definitely publicize and celebrate the wins, and you want opportunities to make more interventions for more wins. So in my last second, I will just say that clinical microbiology and antimicrobial stewardship are essential partners with overlapping missions, so we can work together to achieve our missions. Stewardship interventions come in all variations: lab testing, reporting, culture comments, education. And although implementation of initiatives is challenging, it involves a team, but these interventions can significantly impact patient outcomes, which is what we want for both groups. And with that, I'll just say thank you. This is our antimicrobial stewardship team at Endeavor Health and my clinical lab team, and I'll take questions. Yes.
Thoughts on expanding surveillance techniques for CRG. So from the epidemiology and labs and what is the case versus what is the case, for example. Like CLSI breakpoints they may differ, but then there's not really any standardization, and that's something that I've not really understood. So I cover as an epidemiologist just regional epi for Southern Europe.
Okay.
And a lot of our cases come from Missouri. Now, if you have one area that is not a case, for example, someone being paid off at their venom, for example, and also venom is key. But this state might look something over it. How do you, what is your thought on standardizing?
You know, that's a really hard question. It's a really great question. No, but it's a really hard question because you're right. Not all institutions are going to test the same antimicrobials and they're not going to test them using the same method. So you, unfortunately, at a hospital, you kind of get what you get because we are all making these decisions on antimicrobial discs or panels that we look at there's limited real estate when we're choosing them. And you're looking at what are the drugs that are used most often for a broad spectrum of infections and organisms, and which fit with our formulary at the hospital most closely. And so you are kind of limited in what you can test. You can't just turn on ertapenem if you don't routinely do it. It would require like an entire new panel. So that is very hard. I think that the states, maybe the CDC at that level, I think if they standardize the definition, there's always going to be a little bit of wiggle room in like what's acceptable for a carbapenem to test. You might have to have a variety of if this one or this one or this one kind of situation. But I think if they don't standardize that at the national level, you're going to have a really hard time if you're going from like Missouri to Illinois and they have different state level definitions of like a MDRO or carbapenemase producing organisms. Also, some of it comes down to resources. Like, do you test for carbapenemases by PCR? You're looking for the mechanism, or are you just testing a carbapenem antibiotic and you don't really have the resources to do a molecular test? And that's gets down to, those tests are expensive. And so it comes down to like the priorities of the hospital and what they can afford for their patient population. So I don't have a great answer, but that's probably why there's a lot of mismatch.
Focus being on candidates production. Extensive instead of, for example, CLM, which is and then so there's I find that our border states don't their surveillance is different, so I've always wondered and to be honest, some of our case definitions differ from the CDC, even though we have meetings with them all the time. Can you explain this? Can you explain that? But
I can see that. We definitely try to provide as much information as we can through INEDs and, XDRO registry and things like that. But you're right, it's not currently standardized. If there was funding for that, we would love to standardize, I'm sure. But outside of that, it does get hard because different healthcare systems like prioritize different things. Yeah. Okay, well, with that, thank you.
oh my god! Oh yeah,
That's got some, yes, as you.
I mean, but I wanted to put out there because I'm not, maybe I'm not, maybe I'm free. I didn't think of that.
Well, I just love the, there's some creativity. Some of them feel like it was like kind of bonus ideas.
Yeah.
It's stuff.
Maybe stuff to think about. And like right now, we have a wound comment that's like no, or it's going to be like most, or whatnot.
Yeah, that was one of the ones, because I brought up the, like, so I was like, years ago, and it got shot down, they're like, well, we have to choose with like. Actually, it was Erica's friend, Sunset. Erica, that, her blood sense. They bought it up, yeah, they can roll these together. That's it, we're actually going to be cultures that are. Yeah, and then.
Well, I don't see why you couldn't, if it's there,
you know, obviously you have to figure out what do you do if it's there, if it's below the level of
And I think
significance?
that was maybe like the concern.
Yeah.
It's like, what, this
Yeah.
is like a low.
Yes.